السلام عليكم. إذا كان صوتي واضح أريد أحد يرد علي. هذا زحمة.
وعليكم السلام دكتور. نعم صوتك واضح.
من حضرتك؟
عمار دكتور.
عمار.
نعم دكتور.
شكرا عمار، شكرا. اليوم نبدي محاضراتنا إن شاء الله. بالبداية فد استذكار بسيط للمحاضرة السابقة تريننج. طبعا مشكلة كهرباء معكو. عمار.
نعم دكتور.
هذا patient, this is a young man, fall on the back of his upper limb. يعني دا يمشي زلق، فمن زلق سوى خلى ايديه ورا مو ووقع هالشكل. صار عنده severe pain in shoulder region. severe pain in the shoulder region.
نعم دكتور.
ما يخليك حتى تفحصها، ما يخليك حتى مثل ما يقولون حتى الهواء ما يلوحها. اوكي؟
نعم.
فانت سويت لزيتها اشعه، من جت الاشعه هذه الاشعه قدامك، تقدر تقول لي شنو بيها عمار؟
نعم دكتور. هنا the head of the humerus is displaced anteriorly and medially out of the glenoid labrum or socket. Doctor, this is anterior dislocation of the shoulder.
This is the anterior shoulder dislocation. ممتاز بابا، شكرا جزيلا. إذا this is a case of anterior shoulder dislocation. The head of the humerus مثل ما قال لنا عمار downward صاير جوا الجلينويد and medially. هذا هي الكرايتيريا مال anterior shoulder dislocation. عمار أنت هسه بالامتحان أخذت 80، بس أنا بدي أخلي لك 90. ما يخالف؟ إذا أسألك سؤال شوية صعب.
اوكي.
اكو فد نيرف يصير بي انجري هنا. عادة من يصير عندنا شولدر ديسلوكيشن اكو فد نيرف احنا رأسا نشيكه. ويتش نيرف؟
دكتور الاكسلري نيرف.
ممتاز. طيب عمار انا دخلت 100 هسه. قول لي شلون تفحص الاكسلري نيرف؟
دكتور الاكسلري نيرف تفحص عن طريق ابدكشن او ذا دلتويد خاصة.
هذا المريض هذا المريض مش عنده وجع قوي، فما يخليك تقول له ارفع ايدك، ما يقبل. افحص لي السنسري. وين دور السنسري؟
دكتور بالريجمنتال باج اللي هي المنطقة اللي lower of the deltoid.
عمار ذكرني بالامتحان زين بالعملي بيك. اوكي
ان شاء الله دكتور.
اوكي شكرا جزيلا. طيب هذا another case. هناك البيشنت اللي عمار عالجه كان young و he fall on the shoulder. قلنا الهاندز مالته كانت backward وصار عنده ذيك المشكله. هذا البيشنت لما اخذنا له الاكس راي لقينا غير قصه. منو يعلق لنا؟ علي محسن.
نعم دكتور.
يلا ابو حسين. هذا patient fall on the shoulder region. he is an old age يعني عمره 70 سنة خلينا نقول، وصار عنده severe pain in the shoulder region وبروزز. ثاني يوم هو يلا جابوا لك اياه صار عنده big bruise on the shoulder region. شنو عنده صار هذا؟
دكتور I think the head of humerus first is dislocated and also we have a fracture in the scapula maybe.
fracture scapula يعني السكابيولا دا اشوفه انا الجلينويد مالتها والكوروكويد.
دكتور scapular notch
intact هايني.
ولا scapular notch؟
انا ما ادري يمكن السهم ده يطلع له. مدى يطلع يمك السهم اللي دا اشير به؟ مدى يطلع مو؟ تلاحظ ان الهيومراس البروكسيمال هيومراس الشكل مالته مو طبيعي. صاير عندنا فد مثلث هالشكل جوا، صاير عندنا من هنا. فهذا فراكتشر بروكسيمال humerus, a fracture of the proximal humerus. هذا a fracture of a proximal humerus is a common condition occurs in old age, especially those who had osteoporosis. والاوستيوبروسيس اليوم راح نحكي عنها. علي اكو فد كلاسيفيكيشن هنا. عندنا موضوع الكلاسيفيكيشن. احنا بالاورثوبيديك علاوي نستعمل الكلاسيفيكيشن كلش هوايه. ليش؟ اولا يخلينا نخلي خطه للعلاج، يعني حتى لان احنا عندنا الكسور مو متشابهه. يعني مثلا بالجنرال سيرجري عندهم جولستون ما بيها مثلنا احنا الكسر ممكن الدايركشن يتغير، مو صحيح؟ يعني البيس نفسه قبل شويه اللي حكى عليه عمار، شولدر ديسلوكيشن هو نفس الديسلوكيشن، يصير انتيريور صار انتيريور شولدر ديسلوكيشن، بوستيريور صار بوستيريور شولدر ديسلوكيشن. المانجمنت تختلف. فاحنا الكلاسيفيكيشن مهم عندنا. هذا هنا اكو سبيشال كلاسيفيكيشن. تقدر تقول لنا اسمه ابو حسين؟
والله دكتور ما اذكر والله.
ما تتذكره. اسمه نير كلاسيفيكيشن. وهذا نير كلاسيفيكيشن يقول لنا اذا اكو امباكتد فراكشر، يعني 1 بيس فراكشر، 2 بيس فراكشر، 3 بيس فراكشر، 4 بيس فراكشر. سهل مو؟
نعم.
1 بيس فراكشر اذا البيسز كلها ناس متداخله بناس نسميه 1 بيس فراكشر. اذا 2 بيس فراكشر يا اما الفراكشر من خلال السيرجيكال نيك، لا وحده من التيوبروسيتيز، الجريتر تيوبروسيتي لو ليسر تيوبروسيتي مفصوله. 3 بيس فراكشر معناها 3 قطع صاير. 4 بيس فراكشر معناها الهيد وحده والجريتر تيوبروسيتي وحده والليسر تيوبروسيتي وحده والشاب. فاذا بسيط مو؟
نعم.
هذا شنو فائدته؟ بال1 بيس فراكشر التريتمنت كونزرفاتيف، 2 بيس فراكشر التريتمنت ريدكشن وبعدين كونزرفاتيف، 3 بيس فراكشر انترنال فيكسيشن، 4 بيس فراكشر نسوي ارثروبلاستي. خلاص ها هي كل البروكسيمال هيومرس خلاص. اوكي؟
تمام.
طيب لما اجي انت علاوي اسالك اقول لك علاوي هذا الكيس 1 بيس فراكشر، 2 بيس فراكشر، 3 بيس فراكشر، طبعا راح يصير مشكله لانه نختلف بيها. فحتى نحلها ايش نستعمل؟
دكتور هنا نستخدمه اللي هو الهيد، نشوف الهيد مثلا مقسم كذا، لو لا نشوف مثلا اذا اكثر لاين او اكثر لاين.
بس احنا هسه الهيد اختلفنا به. مثلا انا اشوفه 1 2 3 4 قطع، يجي واحد يقول لي لا دكتور هذا 3، يجي واحد يقول لي لا دكتور هذا 2. حتى نحل الاشكاليه بيناتنا راح تصير شنو دز المريض؟
دكتور لاترال فيو اكس راي مثلا
ممكن لاترال فيو، بس احسن من اللاترال فيو ما دام متوفر هسه والحمد لله والشكر موجود. سي تي فيري جود اكسلنت. سي تي سكان. اوكي شكرا علي. ياسمين هاي شنو الأشعة؟ هذا patient young age he fall on the tip of his elbow or he cannot move his arm severe pain. شنو عنده هذا ياسمين؟
دكتور هذا distal part of the
very good
distal part of the femur. التيبيا.
ياسمين هاي مو تيبيا، هذا هيومرس. اوكي مو هذا هيومرس.
distal part of the humerus.
تعرفين ليش هيومرس؟ لان انا اعطيتكم محاضرات الابر ما اعطيتكم اللور، صح ولا لا؟
اي
تمام. فما معقول اجيب لك اشعه انا ما بشوف الاشياء. المهم اذا هذا فراكتشر ديستال بارت اوف هيومرس. طبعا احنا اهم شيء لما نريد نوصف كسر شنو نوصف به؟ اولا العظم المكسور، قالت لنا ياسمين هذا هيومرس. اوكي. ثاني شيء مكان الكسر، قالت ديستال بارت يعني من نص العظم وانت نازل، هاي مسافه طويله. عاده نقسم العظم اما الى اثلاث يعني مثلا upper third middle third lower third او مقسمه ارباع مثلا 4 quarter يعني upper quarter second quarter third quarter fourth عاده مقسمه اثلاث. اوكي، فهذا الفراكشر تقريبا بالجنكشن between the middle third and lower third، صح لو لا ياسمين؟ صحيح. طيب فإذا احنا أول مرة قلنا this fracture occur in the humerus of the junction between the middle third and lower third. إذا هسه صار عندنا معلوم إنه هذا الكسر مو بالبروكسيمال هيومرس ولا بالميدل هيومرس، إذا بالجنكشن between middle and lower. طيب الشيء الآخر اللي نقول نشوف الفراكشر شكله شلون شكله صاير هذا الفراكشر ياسمين؟
شنو دكتور؟
شكل الكسر مثل ما تتبعين عليه قدامك هسه، شو تشوف منه؟ بالعروض يعني مثلا اوبليك شو تشوفينه؟ اوبليك
هو كسر طولي يعني مو بالعرض.
يعني اوبليك فراكشر.
اوبليك فراكشر.
هذا الاوبليك فراكشر الخطوه الجايه ايش لازم نوصف عدد القطع الموجوده، يعني 2 part 3 part 4 part يعني comminuted او
دكتور سمبل مو comminuted.
simple fracture. very good. فاذا هذا fracture بالهيومراس between the middle third lower third
rejection simple oblique
simple fracture. طيب ياسمين هذا البيشنت اجانا وعنده فد كومبليكيشن غريبه، فد شغله غريبه عنده. اخلي الفوطه بالخبز العكس. ياسمين هذا البيشنت من اجانا كان عنده فد مشكله بالرست مالته. شنو هاي المشكله؟ ايش تتوقعين ايش صاير بالرست؟ الرست جوينت، واحنا وين الرست جوينت؟ احنا عندنا ني البو جوينت، يلا نوصل للرست جوينت، بس هو الرست جوينت كان به مشكله. ايش كان عنده بالرست مالته؟
دكتور هي اما انه الكاربال بون تاذت او سبليكيشنز بالرست؟
لا بعد هو هذا الكسر بهالمكان هذا ممكن يسبب لي مشكله بالرست. هذا هنا ممكن ان يصير عندي انجري للراديال نيرف. اذا تتذكرين بالاناتومي مال الصف الثاني الراديال نيرف يفوت بالجروف مو posteriorly يسوي تيرن اراوند هنا سمينا وقتها، وهذا ممكن يعطيني ريست دروب. شكرا جزيلا ممنون. Now we will discuss the lectures. راح نرجع للمحاضرات مالتنا والعملي ان شاء الله احنا مستمرين به وراح ناخذه بالتفصيل ان شاء الله اذا يعني سمح لنا الوقت اثناء المحاضرات او في السيشنات القادمه او ان شاء الله السيشنات العمليه اللي نسويها ان شاء الله بالكليه او بالمستشفى. These are the group of lectures, two lectures actually, concerned about the tumors. Tumors موضوع كلش مهم عندنا بالأورثوبيديك ويشمل الترو tumors وأكو بعض القضايا اللي تشبه التيومرز اللي أيضا تشمل بهذا الشابتر. فخلي نبدأ المحاضرة. Tumors. This lecture includes the tumor and tumor-like conditions that actually not tumors, but they are seen in the bones and discussed in this lecture. Diagnosis. What are the symptoms of bone tumor? Pain, swelling, tenderness, pathological fracture. Can we see bone tumor accidentally? Yes, we can see many of bone pathologies accidentally because either they are symptomless or they are very small to give, or at the early stages of the pathological changes, and we can see them. Clinically, is the tumor benign or malignant? Can we diagnose the tumor as a benign tumor or malignant tumor clinically? Actually, there is some science may give an idea about that, but it is not 100% diagnostic. Like rapid growth, warm, tender, ill-defined age. Is the clinical diagnosis enough to establish treatment without biopsy? Here there is a controversy about this subject. Some advise to do surgery, others not accept that, especially the oncologist. And from a scientific point of view, biopsy is very essential for the diagnosis, to prove the diagnosis of the tumor and to stage it, give the histological staging of the tumor, whether it is highly malignant or low malignant. What are the investigations needed to establish the diagnosis? X-ray, CT scan, MRI, radionuclide scanning, and biopsy. What are the most useful imaging technique? Plain X-ray is the most useful imaging technique. Plain X-ray can give us clue about the appearance of the lesion, location of the lesion, type of periosteal reaction, the matrix, clue about the density of the lesion, and about the number of the lesion. كل bone tumor عادة يقع في مكان معين من العظام. يعني مثلا osteosarcoma موقع مالها بالميتافيسيس، يكاد من المستحيل أن تلقاها بالدايافيسيس أو تلقاها بالإبيفيسيس. كودروبلاستوما تلقاها بالإبيفيسيس. فهذا يعطينا دليل على أنه كل تيومر إلى مكان معين. هاي نقطة. النقطة الثانية، كل تيومر إلى طريقة معينة في تحفيز البريوستيوم، وكل تيومر إلى كرايتيريا معينة من ناحية الماتريكس، مادة اللي بالأشعة شلون تظهر عندنا. كان يكون مثلا calcification أو ossification أو sunburst appearance, haziness. بعدين كل تيومر إلى يعني أكو قسم من تيومرز single lesion وقسم multiple lesion. بنناقشها بالتفصيل إن شاء الله في الكلينيكال. What are the roles of MRI and CT scan? They will give us the true extent of the tumor and the relationship of the tumor to the structure, whether it had invaded the structures or not, and whether the tumor is still in the compartment, in its own compartment, or extended outside that compartment. What is the role of radionuclide scanning? It is important to diagnose skipped lesion, small tumor, silent secondary deposit. Biopsy. Why biopsy is important? Biopsy is important for two reasons. First, to prove the diagnosis. Second, to give the histological grading of the tumor. What are the types of biopsies? There are many types of biopsies. Wide bone needle biopsy, incisional biopsy, excisional biopsy. What are the important rules for getting biopsy? In orthopedic surgery, biopsy is very important, especially in bone tumors. The most experienced surgeon in the team should perform the operations. This is number one. Number two, the tissue should be representative. We have to take a block of a tissue consisting of normal cytocapsule and the tumor cells, the tumor tissue, to see the histological changes. And we have to look very carefully for the hemostasis to secure the bleeding, and the incision should be in the way of the planned future surgery, so that the scar can be excised in future surgery. And drain should be taken care of, also the tourniquet. Frozen section. What is the importance of a frozen section? Frozen section, we take a piece of bone, a piece of the tissue, and we send it immediately for histological examination. This is important to give us the idea about that the tissue we have taken is a representative of the tumor. It does not give diagnosis, but only give us an idea that this is actually a tumor. Who will do the biopsy? We said that the most senior surgeon should do the biopsy. What is excisional biopsy? Excisional biopsy is some sort of surgical procedure in which we excise the tumor, all the tumor. Which is first, biopsy or CT scan and MRI? Well, biopsy will change the picture of the tumor. We advise to do CT scan MRI before doing the biopsy because it is much easier and give us an idea about the extent of the tumor and the relationship of the structure to the tumor. Some of the differential diagnoses of the tumor, chronic osteomyelitis is one of the differential diagnoses of the tumor because there is newborn formation and there is bone destruction, periosteal action. All of these things can give a false impression that this is a tumor, especially if the constitutional symptoms has been suppressed by antibiotics. So bacteriological examination and biopsy can prove the diagnosis. Citrus fracture. Citrus fracture is a fracture occurs due to repetitive minor trauma. And usually the patient does not know that he had the fracture, but he presented with pain, swelling, tenderness at one of the bones, sometime around the knee joint, sometime in the metatarsal bones. And when you take an X-ray, you can see that there is haziness, there is periosteal reaction. It gives us an idea that it may be a tumor. Biopsy, also the callus formation may mimic the osteosarcoma. So it's very important to have an opinion of an orthopedic surgeon, of pathologist, radiologist, in order to avoid this problem. other differential diagnosis. The X-ray labeled with the green arrow show what we call a bone infarct or bone island. The one with the yellow arrow show hypertrophic non-union. The one with red arrow show a fracture, pathological fracture through bone infection. And the one with blue arrow show gout, and this is an excavation of the gouty arthritis. Principles of treatment. Benign lesions that are asymptomatic. Usually, benign lesions that are asymptomatic does not require treatment, only follow-up. Benign lesions that become symptomatic or start to enlarge, like in case of exostosis, become enlarging, or it may cause a pathological fracture. In this condition, treatment is required. And usually the treatment by intracalcular excision or marginal excision. If we suspect the tumor is a malignant tumor, what we shall do? We shall approve our diagnosis, and we have to grade the malignancy, and we have to check for spread. So we have 3 things to do: diagnosis, grading of the malignancy, whether it is high-grade tumor or low-grade tumor, and we have to see the spread of the tumor, whether it is inside the compartment, extra compartment, or it spread to other organs. How can we do that? By doing the usual investigation: X-ray, MRI, CT scan, radionuclide scanning, and biopsy. We have 2 terms: intracompartmental lesion and extracompartmental lesion. What they are? What do we mean by intracompartmental lesion? If the tumor located in its primary location and does not extend beyond that primary location, we call it intracompartment lesion. Example: if we have an osteosarcoma located in the metaphysis of a femur, and it does not extend away from the bone, does not breach the cortex and pass below the periosteum, where there is no natural barrier for it, we call it intracompartmental lesion. If the tumor extends from the metaphysis, the primary location for it, and then to become subperiosteal by breaching the cortex, it is called extracompartmental lesion. If the tumor is low malignancy and has no distant spread, and it is still intracompartment, we can use wide excision. By wide excision, we remove the tumor, wide margin of the bone, and we remove the tumor without opening the tumor, without opening the margins of the tumor. We take the normal away from the tumor, and we take normal bones. Radical, when the tumor is highly malignant, but it does not pass extra compartment, usually we go for radical excision. radical excision, we remove all the compartment. Example, مثلا, if we have a tumor in the femur and the tumor has not reached the cortex, it's still in the femur, but the tumor is highly malignant, so it is still intra-compartment, and when we investigate the patient, we haven't seen any spread, any skip lesion, any distant metastasis, so we can do radical resection. Sometimes we can go for prosthetic replacement when we do radical resection. If the tumor is highly malignant, but it is extra compartment, we do amputation. Limb sparing surgery, if we do radical resection or wide local resection, we want to, or instead of doing amputation, if we can spare the limb by putting a prosthesis and supplying the patient with the chemotherapy, there is a trend to do limb sparing surgery. Multi-agent chemotherapy, by giving the protocols for chemotherapy for the tumor and radiotherapy for sensitive tumors for radiation. Benign bone lesions. Non-ossifying fibroma. The incidence, this is a very common benign bone lesion. What is it? It is a nest of fibrous tissue within the bone. Usually incidental finding and asymptomatic. It occurs in young age group and in children. Site or long bones could be affected, and usually the usual site in the metaphysis of the long bones. Occasionally multiple lesions. Number, usually single lesion, sometimes multiple lesion. X-ray. The X-ray is show an oval radiolucent area in or adjacent to the cortex. Oval radiolucent area in or adjacent to the cortex. Actually, is it solid? Yes, it is solid. It consists of fibrous tissue. Treatment, no need for a treatment except when it causes pathological fracture. Can be enlarged? Yes, sometimes can be enlarged. Fibrous dysplasia. Fibrous dysplasia is a developmental disorder in which is area of a trabecular bone are replaced by fibrous tissue, osteotissue, and woven bone. At operation, the lesion tissue has a coarse, gritty feel due to the spikes of immature bone. The condition may affect one bone, monostotic, one limb, monomelic, or many bones, polystotic. Malignant transformation to fibrosarcoma occur in 5 to 10% of patients with polystotic lesion, but only rarely in monostotic lesion. Clinical features. Small single lesions are asymptomatic. Large monostotic lesion may cause pain and bone deformity, or may be discovered only when the patient had pathological fracture. X-ray. cyst-like area in the metaphysis or shaft have hazy, so-called ground glass appearance. The weight-bearing bone may be bent, and one of the classic features is the Shepherd-Crook deformity of a proximal femur. Pathology. The histological picture is of a cellular fibrous tissue with patches of woven bone and scattered giant cells. Treatment. Small lesion need no treatment. Those that are large and painful are treated with, are threatened to fracture or have been fractured, can be curated and grafted. But there is strong tendency for the abnormality to recur. Deformities may need correction by suitable designed osteotomies. These are different X-rays for fibrous dysplasia. The one on the right showing the humerus and the lesion extended from the head of the humerus, metaphysis, and to the mid-diaphysis. The lesion is hazy, and you can see what we call a ground glass appearance, and there is a partition inside the bone. You can see it, white partitions inside the bone. These are the osteoid and woven bone that is not mature. The fibrous dysplasia, actually the complex bone, mature bone, will regress, and we will have osteoid tissue, that is a tissue of bone without calcification, and woven bone, that the bone with haphazard arrangement of the collagen fibers and fibrous tissue. The one in the middle, we see what we call a deformity of Shepherd-Crook deformity of the femur, and we can see there is a pathological fracture. In the tibia, the one on the left, we see a tumor-like condition that that's an extension involving whole diaphysis, part of the metaphysis, and there is there's haziness, and there's speculation, septation, partitions, and some extension. This is a classical of fibrous dysplasia. Osteoid osteoma. This is a benign tumor consisting of osteoid and the uniform bone. It is small, usually less than 1 centimeter in size, round or oval in shape, and is encased in dense bone. It is usually seen in patients aged under 30 years, and over 1/2 of the cases occurs in the femur or tibia. The leading symptom is pain, which is sometimes so severe it prevents the patient from sleeping at night, and usually relieved by aspirin, but not the rest. X-ray. The important feature is a tiny radiolucent area, the so-called nidus. In the diaphysis, the nidus is surrounded by dense bone, and the cortex is thickened. Lesions in the metaphysis show less cortical thickening. It is sometimes difficult to distinguish an osteoid from a small body abscess without biopsy. Treatment. The only effective effective treatment is to complete removal of the nidus. The lesion is carefully localized by an X-ray and or CT scan and then excised in a small block of bone. The specimen should be X-rayed immediately to confirm that it does contain the little tumor. Chondroma or inchondroma. This is an evidence of hyaline cartilage in the metaphysis of the bone that developed from enchondral ossification. In the center of the hyaline cartilage, there will be a calcification and degeneration. Clinical features. Enchondroma usually asymptomatic. It will discover incidentally and it can affect any age. It may cause pathological fracture and usually the lesion is solitary or multiple. If it is multiple, it will be part of generalized dysplasia. X-ray, there will be a central, sometimes expanded, radiolucent area, and what distinguishes it from the other cyst-like lesion is the presence of flakes of calcification within a lucent area. Those pointed by the arrows. Treatment. If the tumor painful or is enlarged, or there is presence of pathological fracture, it should be removed and using urethral and graft. Prognosis, there is a small significant percentage of malignant changes. What is suspicious features in adult patients are onset of pain, enlargement of the lesion, and cortical erosion. If these features are present, and especially in older patients, the tumor should be treated as a low-grade malignancy, low-grade chondrosarcoma. In the X-ray on the left side, with the blue arrow, you can see a central osteolytic lesion, the metaphysis of the proximal lines of the index finger, and there is a pathological fracture below the arrow. In the X-ray, with the yellow arrow, you can see an osteolytic lesion involving the metaphysis extended to the axis of the radius with slight expansion, and there is flakes of calcification. Thus, very white shadow has been pointed by the yellow arrow in the lesion. These two X-ray, one of the first differential diagnosis is enchondroma. Osteochondroma, exostosis. This is a very common pathology. It is actually a developmental disorder due to outgrowth of cartilage at the edge of the physical plate. Occurs in bones that originated from endochondral ossification, especially in the fast-growing bones, long bones, and in the ilium. Sometimes it is a part of generalized genetic malformation called hereditary multiple exostosis. We will discuss it later, and the genetics. There is a possibility of malignant transformation, 1% for solitary lesion and about 6% for multiple lesions. Clinical feature: the lesion usually appear in teenage group, patient adults, and the exostosis may be enlarging up to the end of the normal growth period. Any further enlargement after end of the growth may suggest malignancy. X-ray: well-defined bony protuberance, exostosis emerging from the metastasis. It looks smaller than its actual size because of the cover with the cartilage, and large lesion they will undergo cartilage degeneration and calcification, and then the X-ray show the bony exostosis surrounded by blobs of calcified material. Treatment: if the tumor causes symptom, it should be excised. If an adult and it has recently become bigger or painful, then operation is urgent. For the feature suggesting these features suggest malignancy, even if the histology looks benign. The possibility of malignancy in pelvic exostosis is bigger than that of the long bones because they may grow to a big size without noticing it. Control laptop. This is a very rare condition. The most important thing about it is patient located in the epiphysis. This is one of the very few lesions that occur in this. Consists of immature cartilage cells and usually can cause some pain and tenderness at the site of the lesion. X-ray regulation lesion and the epiphysis treatment. In immature bones, that is in children, and when it is accessible, we may do surgery by operation. If it is adult, we can do operation and body part. Chondromyxoid fibroma. This lesion occurs mainly in young adults. It may affect any bone, any long bone, especially those of the lower limb. Patient usually have no symptoms and accidentally finding or following pathological fracture. On the X-ray, there is an oval shaped radiolucent lesion occur in the metaphysis of the long bones eccentrically. Pathology: it consists of a cartilage, fibrous tissue, and eczematous tissue. Treatment: usually chelated and bone graft. simple bone cyst. This occurs mainly in children. It is not a tumor. Commonly occur in the metaphysis of the long bones, proximal humerus and femur. And the end result is spontaneous healing, so that it is not seen in adult life. Sometimes presented as a pathological fracture. In the X-ray, a bubble inside the bone. You can see an osteolytic lesion in the metaphysis of the low bones, extended up to the epiphyseal plate, but it does not cross the epiphyseal plate. It does not cause any bony expansion or metaphyseal or periosteal reaction. Treatment, we have to differentiate between two types, the active cyst and the inactive one. The active cyst, when the cyst is still connected to the epiphysis and it is enlarging in size with the sequential exercise. In this case, we advise to do curating and bone graft or local injection of steroid. After respiration, the fluid, amber color fluid inside the cyst. The injection of steroid had a lot of controversy whether it is induced healing or the process of piercing the cortex initiate healing. Recently, bone marrow injection has been advised. In non-active cyst, those cyst has been separated from the epiphysis and it is not enlarging in size with sequential X-rays, usually treated by advising the patient to take care of trauma that may cause pathological fracture, and the cyst will heal spontaneously. Aneurysmal bone cyst, a sponge in the bone, not like simple bone cyst. This is cystic tumor-like lesion which occurs chiefly in spine and metaphysis of long bones, usually affecting young adults. It may expand the bone and cause marked thinning of the cortex. When the cyst is open, it is found to contain clotted blood, and during curettage, it may show considerable bleeding from a fleshy lining membrane. Histologically, the membrane consists of the fibrous tissue with vascular spaces and deposits of hemosiderin, multinucleated giant cells. There is no risk of malignant transformation. X-ray, in a growing tubular bone, the cyst is always situated in the metaphysis and may resemble simple bone cyst. In adults, it can be mistaken for giant cell tumor. But unlike the later, it is boundary stop well before the cartilage, before the articular margin. Treatment, the cyst should be thoroughly curated and then packed with bone grafts. Sometimes the grafts are resolved and the cysts recur, necessitating, in this condition we need to do second or third operation. And the X-ray, always remember that the tumor is expanding the cortex, not like the simple bone cyst, and it cannot pass the epiphyseal plate. Giant cell tumor. This tumor is uncertain origin. It appears at the end of bones. Usually the bones are mature. Most commonly in the distal femur, proximal tibia, proximal humerus, and distal radius. The tumor has reddish, fleshy appearance. It comes out easily in pieces, but it's difficult to remove completely. Aggressive lesions have a poorly defined floor and appear to extend into the surrounding tissue. Histologically, multinucleated giant cells scattered in background of stromal cells. 1/3 of the tumor remain truly benign, 1/3 become locally invasive, and 1/3 give metastasis. So it is a benign tumor that may give metastasis. Clinical features: the patient is usually young adult who complain of pain at the end of the long bones. Sometimes there is a slight swelling. Pathological fracture occurs in about 10 to 15% of the cases. Clinical features: X-ray imaging. Although this is a solid tumor, it appears on X-ray as a cystic lesion, radiolucent area situated eccentrically at the end of the long bones, mature bones. The cystic lesion is always extend right up to the subchondral bone plate. The industrial margin is usually clear-cut, but the invasive lesion is ill-defined lesion. CT scan, MRI is very important because the tumor had the possibility of aggressive behavior and malignant transformation, and sometimes we need to do arthroscopy because the tumor passed to the subchondral bone. Biopsy is essential. Treatment: tumor can be treated well by thorough curettage and adding bone graft in the lesion. Quiz. Giant cell tumor is a benign tumor that may give metastasis. Question: is another benign pathology that gives metastasis? This slide we can see the quick revision of the benign pathologies we have discussed previously. Solitary bone cyst, usually in the upper limb, metastasis, and presenting the pathological fracture just a little inside the bone. The metastasis, usually there is an expansion of the bone and eccentric. Bone and it's usually cortical, each finding expanding ground glance appearance. Chondroma, there is a calcification inside the lesion, osteolytic lesion. Chondromic solid fibroma, eccentric and dense industrial margin. Chondroblastoma occurs in the epiphysis. Giant cell tumor usually appear in the mature hormone and always extend up to the subarticular margin, and in every case you have to remember to look for the hyperparathyroidism. Thank you very much. حقيقة أكو في التوجيه شلون نقرأ هذه المحاضرة. احنا سمعنا أسماء كثيرة وسمعنا تفاصيل كثيرة. لما تشوف المحاضرة هذه أول مجموعة سلايدات هي عبارة عن أسئلة أنا سألتها وجاوبت عليها. فهذه هي المهمة، يعني أنا أقرأ السؤال وأسمع الجواب، وهذه هي اللي تلخص لك كل المحاضرات سواء كانت التيومر بناين أو المالجنانت تيومر. هاي وحدة. وبعدين من تجي على التريتمنت تشوف أكو خريطة لعلاج التريتمنت لعلاج التيومرز كلهم يعني. فإذا ناخذ فكرة عامة من أول مجموعة سلايدات. من نجي على الموضوع الثاني يعني الكونديشنز اللي ناقشناها. كل كونديشنز احنا خليت اني جوا الاسم مالتها فد كلو حتى انت تعرف شلون تقراها. مثلا simple bone cyst لما تشوف العنوان تقرا جوا مكتوب a bubble inside the bone. هذه الببل انسايد ذا بون هي مفتاح اللي يخليك تفتهم شنو السمبل بون سيستم. يعني الببل هاي عباره عن فقاعه، الفقاعه داخلها فراغ، تمام؟ الفقاعه راح تبقى تكبر ما دام هي متصله بالمصدر مالتها اللي هو الابيفيسيس، مثل ما الفقاعه تبقى تكبر ما دام هي متصله يعني باللي ينفخها. الفقاعه تنتهي وقت ما تنفصل عن المصدر. الفقاعه ما تقدر، ما عندها قدره انه تتوسع العظم. الفقاعه لما انت تسوي لها لوكال انجكشن، يعني لما تثقب الفقاعه هي راح تنفجر، مو صحيح؟ هاي طريقه انه احنا خلينا في كل موضوع اكو كي جوا الاسم، هذا من تحفظه راح يسهل عليك حفظ كل التيومرز. الآن ناخذ استراحة لمدة 10 دقائق وبعد ذلك نناقش المالجنانت بون تيومرز. شكرا. Tumors, Part 2. Primary malignant bone tumor. Osteosarcoma. The classic form of osteosarcoma is a highly malignant bone tumor arising within the bone and spreading rapidly outward the periosteum and surrounding soft tissue. The histological appearance variable. The classic form is spindle cell and osteoid matrix. Other contain fibroblast tissue and cartilage. Usually it is very rapidly growing tumor. It can appear in children and adolescents usually, and it can affect any bone but has special predilection for long bones, especially around the knee and the proximal humerus. The pain is the constant feature, usually increase in severity, especially at night, and reach a state where it will be very, very severe. Local tenderness and mass start to appear, and with the time this mass become increasingly, and the tissue over the mass become inflamed. ESR and alkaline phosphatase may be raised. On X-ray, some of the tumors are osteolytic, others may show osteolytic and increased bone density. The tumor margins are poorly defined. Often the cortex is breached and the tumor extended into the adjacent socket. When this happens, streaks of newborn appear, radiating outward from the cortex, and this is called sunburst appearance, which has been labeled by the red arrow. Where the tumor emerges from the cortex, reactive newborn formation in the angle between the periosteum and cortex, called Kadum triangle, has been labeled by blue arrow. While both the sunburst appearance and Kadum triangle are typically of osteosarcoma, they can occur in any other rapidly growing tumor. Other imaging required are radioisotope scan to detect the skin lesion, CT and MRI to detect the extent of the tumor, chest X-ray, and CT scan, pulmonary CT scan, to detect the metastasis, labeled in black arrow, and about 10% of cases had lung metastasis when they are first diagnosed. Diagnosis, most of the cases, the diagnosis is enough by seeing the X-ray, but it can have some similarity to other benign conditions like chronic osteomyelitis and gouty tophi and stress fracture. So biopsy should be done. Treatment, the principle of the treatment is the same as any malignant tumor. Chemotherapy is given for 8 to 12 weeks, and after that, the tumor is resectable and there is no skin lesion. Wide resection is carried out. If the tumor extends beyond the compartment, usually we do radical resection plus chemotherapy. These are multiple X-rays for cases of osteosarcoma. As you can see, the tumor is osteolytic in some of the X-rays and alternating osteolytic and osteoplastic in the others. And you can see the Kadum triangle and the pointed by the red arrow and the sunburst by blue arrows. MRI, very important to see the extent of the tumor. As you can see in the X-ray, the tumor has occurred in the bone, but by the checking the MRI, you can see the tumor is extended outside the bone. Chondrosarcoma. Chondrosarcoma, either primary or secondary to a benign cartilage tumor like chondroma or exostosis, especially if exostosis occurs in the pelvis or in the scapula, because they may grow without being noticed. Chondrosarcoma divided histologically into low grade, which is similar to benign malignant tumor, benign cartilage tumor, sorry, or high grade with multiple pleomorphism and mitosis. Clinical feature: chondrosarcoma occur mostly at the age of fourth and fifth decades. Men affected more than women, and tumors are slowly growing and usually presented for many months before they become discovered. Patient may complain of dull ache pain and gradually enlarging mass. Sometimes pathological fracture. Imaging. Primary chondrosarcoma usually appear as a radiolucent area in the metaphysis of the long bones and sometimes in the pelvis, with central flakes of calcification. Other lesion may be similar to that of benign cartilage tumor. Secondary chondrosarcoma usually arise in the cartilage cup of the osteochondroma that has been presented since childhood. Large osteochondromas with widespread calcification in the cartilage cup should be viewed with the suspicion, and main osteochondroma that increase in size after the end of the normal bone growth should be regarded as definitely malignant. CT MRI should be performed before biopsy. Treatment. Chondrosarcoma are usually slow growing and metastasize late. They presented the ideal case for wide excision and prosthetic replacement, provided it is certain that the lesion can be completely removed without exposing the tumor and without causing an unacceptable loss of function. Otherwise, amputation may be a safer option. The tumor does not respond to either chemotherapy or radiotherapy. Ewing sarcoma. Ewing sarcoma arise from endothelial cells of the bone marrow, occur at age between 10 and 20, and usually affect tubular bone, especially the tibial, fibula, or the clavicle. The tumor is lobulated, often fairly large macroscopically, and microscopically there is sheath of small dark polyhedral cells with no ground substances. Clinical feature: the patient presented with pain, often throbbing in character, swelling, generalizedness, pyrexia, together with warm, tender swelling and raised ESR. All these pictures similar to osteomyelitis, acute osteomyelitis. Diagnosis: X-ray usually show an area of bone destruction. Osteolytic lesions usually appear in the diaphysis, in the mid-diaphysis, unlike that of osteosarcoma, which is usually in the metaphysis. The osteolytic lesion appear in the mid-diaphysis. New bone formation may extend along the shaft, and sometimes it appears as fusiform layers of bone around the lesion, what is called onion peel appearance. CT and MRI may reveal any large extra-osseous component, and radioisotope scan will show any skin lesion. Diagnosis: the condition which should be excluded as rapidly as possible from bone infection. On biopsy, the essential step is to recognize this is a malignant round cell tumor. Other round cell tumor that may resemble sarcoma is reticular cell sarcoma and metastatic neuroblastoma. Treatment, the diagnosis is always poor and treatment, the prognosis is usually poor. And surgery alone does little to improve it. Radiotherapy has a dramatic effect on the tumor, but overall survival is not much enhanced. Chemotherapy is more effective. Usually, a combination of all three modalities, radiotherapy, chemotherapy, surgery, has been advised. Multiple myeloma. Multiple myeloma is a malignant B-cell lymphocytes with plasma cell predominating. The effects on bone are due to monocell proliferation and increased osteoclastic activity, resulting in osteoporosis and appearance of discrete lytic lesions throughout the skeleton, myelomatosis. Clinical feature, the patient typically aged 45 to 65, presented with weakness, backache, bone pain, or pathological fracture. Hypercalcemia may cause symptoms such as thirst, polyuria, and abdominal pain. Associated features of the marrow cell disorder are plasma protein abnormalities, increased blood viscosity, and anemia. Bone resorption lead to hypercalcemia in about 1/3 of the cases. Late secondary features are due to renal dysfunction and spinal cord or root compression caused by vertebral collapse. The prognosis in established cases is poor, with median survival between 2 to 4 years. X-ray only show nothing more than generalized osteoporosis, but remember that myeloma is one of the commonest causes of osteoporosis and vertebral compression fracture in men over the age of 45. The classical lesions are multiple pulsed out defects in the skull, pelvis, and the proximal femur, a crushed vertebra, or a solitary lytic tumor in the large bone metastasis. Investigations, while anemia is common, most constant feature is high ESR. Blood chemistry may show raised creatinine level and hypercalcemia. Over 1/2 of the patient have Bence-Jones protein in the urine, and serum protein electrophoresis show characteristic abnormal band. Sternal marrow puncture may show plasmacytosis with typical myeloma cells. Diagnosis. If the only X-ray changes is osteoporosis, the differential diagnosis must be include other causes of bone loss. If there are lytic lesions, the features must be similar to those of metastatic bone disease and should be excluded. Paraproteinemia is a feature of benign gammopathies and it should be excluded also. Treatment, the immediate need for pain control and the necessity of the diagnosis of pathological fracture with the nerve fixation and bone chips, and sometime in there is a possibility of compression of the spinal cord, so we have to stabilize the spine by doing internal fixation. The treatment of hypercalcemia is very important, treatment of anemia is very important, and the specific cytotoxic treatment such as with milfillar and corticosteroid may be advised. Metastatic bone disease. The skeleton is one of the common signs of secondary cancer. In patients over 50 years, bone metastases are seen more frequently than all other primary malignant bone tumors together. The commonest source is carcinoma of the breast. Next in frequency are carcinoma of the prostate, kidney, lung, thyroid, bladder, and gastrointestinal tract. In about 10% of cases, no primary tumor is found. Where the tumor settles. The commonest site for bone metastasis are the vertebrae, pelvis, the proximal half of the femur, and the humerus. How it will spread? Spread is usually via the bloodstream. Occasionally, visceral tumor spread directly to adjacent bone, like in pelvis and ribs. What is the common type of metastasis? Metastases are usually osteolytic and pathological fracture are common. When bone resorption occurs. Bone resorption is due either to the direct action of tumor cells or to tumor-derived factor that stimulate osteoclastic activity, which tumor produce osteoblastic lesion. Osteoblastic lesions are uncommon. They usually occur in prostatic carcinoma. Clinical features. Presenting symptoms, usually pain, sudden collapse of vertebrae, vertebral body, or a fracture of the midshaft of long bone in an elderly person or hominid sign. If there is no history and no clinical clue pointing to the primary carcinoma, a biopsy of the fracture area is essential. If X-ray do not show anything, a radionuclide scanning is done. Symptoms of hypercalcemia may occur and are often missed in patients with skeletal metastasis. These include anorexia, nausea, thirst, polyuria, abdominal pain, generalized weakness, and depression. In children under the age of 6, metastatic lesions are most commonly from adrenal neuroblastoma. The child presented with bone pain and fever. Examination revealed the abdominal mass. Investigations, X-ray, radio, scintigraphy, special investigation, ESR may be increased. Hemoglobin concentration is usually low. Serum alkaline phosphatase concentration is often raised. And prostatic carcinoma, the acid phosphatase is also elevated. Patients with breast cancer may screen for measuring blood level of tumor-associated antigen marker. Treatment. Prognosis depends on the first, solitary, secondary, and primary or blind resection. So we do radical resection plus chemotherapy, such as in case of hypernephroma and thyroid. In multiple secondaries, usually treatment is symptomatic. Don't forget that tumor enabled to hormonal treatment should advise hormonal therapy. The aim of treatment in metastatic bone disease usually is to, unfortunately, to say that is the statement that die, make your patient die in peaceful way and dignified way. And this aim can be achieved by controlling the pain, and metastatic activity by radiotherapy, hormonal therapy, treatment of hypercalcemia, treatment of a fracture, prophylactic fixation, and spinal stabilization. Thanks and God bless you. Thank you very much. ناخذ استراحة لمدة 10 دقائق ونرجع نكمل إن شاء الله.